It's now time for my last presentation for today. This is the outline of the presentation. I give some information about the natural history of thyroid cancer, the standard follow-up, treatment options, what to do, but the most important thing is what are we going to do if radioiodine therapy is not an option anymore. This morning we heard already something about genetic alterations in thyroid cancer. And if you want to know something about prognosis, survival, and subsequent treatment during follow-up, you have to know at least something about the genetic alterations. And as you can see in this, on this slide, you can see here that already from the thyroid gland, the normal features of the thyroid cells, there can be an alteration in the cells which is related to oncogenes or a rearrangement of the natural genes already in cells present. And that might cause already the induction from the normal thyroid gland into benign neoplasms. So there is already something going on with genetic alterations when we talk about benign neoplasms. And usually, of course, it's an adenoma, but you have to realize that the step from a normal cell goes via this pathway by genetic alterations into papillary thyroid cancer or into follicular thyroid cancer. And it depends, in fact, mainly on rearrangements or mutations that can be observed whether we are dealing with papillary thyroid cancer or follicular thyroid cancer. I'm not going to talk about poorly differentiated thyroid cancer, for example, the Hürthle cell carcinoma, but it may be a scala ranging from here till the undifferentiated cancer that can be observed. And you have to be very careful, and that is also important for prognosis and your treatment options. During follow-up, it may go on and on and on. And maybe some of these steps here are also responsible for the de-differentiation steps in thyroid cancer. And it means that it can go straight forward from follicular cells, the normal cells, to undifferentiated or atypical thyroid cancer, but maybe also some steps are involved from well-differentiated into the undifferentiated thyroid cancer or the de-differentiated thyroid cancer. And that is highly important to realize. When you have a look at the genetic alterations in thyroid cancer, it's good to realize that there are some differences between papillary thyroid cancer and follicular cancer. And one of the most important differences is that BRAF mutations are often observed in papillary thyroid cancer, where in follicular thyroid cancer it's rare. And if you want to treat a patient with follicular cancer with BRAF inhibitors or whatever, you see that the chance of curing or at least doing something in the patient with follicular cancer is low. In contrast to the papillary thyroid cancer, it might be an option at the end when radioiodine is not an option anymore. Also here, the PTEN mutations and the red PTC mutations, there are differences between papillary and follicular thyroid cancer, and here at the end you see the atypical thyroid cancer. It's good to realize that there are differences. Keep that in mind, because it might help you in making decisions in what to do. When we talk about the natural history of thyroid cancer, from the beginning on, it's good to realize that some of the patients already have lymph node metastases from the beginning on. And usually it's observed in papillary thyroid cancer, that is what we know, but it can also be observed in follicular cancer. However, the chance of finding lymph node metastases is the highest in papillary thyroid cancer compared to the follicular variant. Death from disease, it is rare, but the risk of dying from this disease is in follicular cancer slightly higher compared to papillary thyroid cancer. And of course, the prognosis of thyroid cancer is still very, very good, extremely good. Dying from disease in follicular cancer, I think this percentage is slightly high, but it gives you a good idea that the prognosis overall of papillary cancer is slightly better than in follicular cancer. What about the recurrence rate? and that says something about the genetic alterations behind the two tumor types. The recurrence rate is high. It's not 0%, and even if you do optimal ablation and surgery, we still observe recurrences in 90% of the patients with papillary thyroid cancer and up to 29% of the patients with follicular cancer. So we can do quite a lot of good things with radioiodine and surgery, but you see there is still a recurrence rate observed in clinical practice. The value of radioiodine is to lower this percentage. That is why we achieve results like that, and like that in follicular cancer. If we do not apply radioiodine ablation, this percentage is definitely higher. And that is what we told you this morning. Radioiodine in patients with an intermediate or high risk definitely require radioiodine treatment to lower the recurrence rate. That is highly important. Now, when you look at the site of recurrences, it is good to realize that there are differences between papillary and follicular thyroid cancer. Usually, or quite often, when there are recurrences observed, they are in the head and neck region related to papillary thyroid cancer. In contrast, you see this percentage is lower in follicular cancer. So if there is a recurrence, usually it's in the head and neck region of papillary thyroid cancer. In contrast, you may find more distant metastases related to follicular cancer. That's also a thing you have to keep in mind. If you are dealing with increased thyroglobulin levels in a patient with follicular cancer, you hope to find it in the neck, in the head and neck region, but if not, please go on with your imaging techniques because you might miss distant metastases. Keep that in mind. On the contrast, you see ultrasonography and thyroglobulin levels. In a majority of the patients, you will definitely find the recurrence. Now, what about the time interval of the recurrences after initial treatment? What you see here, it's a nice paper published in 2013 in the European Journal of Endocrinology. When you have a look at the recurrence rate, you see that when we look at all patients treated for differentiated thyroid cancer, the recurrence rate is the highest in the first 2 years. You see that presented in this plot. So there is a high incidence rate in the first 2 years. The recurrence rate is high. Are the differences between papillary and follicular cancer? Well, in fact, not really. And that means that at least in the first 2 years after treatment, you have to do a very close, thorough follow-up with ultrasonography and thyroglobulin measurements, and that's purely based on studies like that. Recurrences observed within 2 years. Of course, there are some other data. When you look at this paper, it's from previous century, you see that in the first 5 years, recurrences can be observed, and to my knowledge, current restaging strategies are based on a thorough follow-up period of 5 years, and thereafter, there is no need for a 3 or 6 month testing anymore. You can do it once a year. The question is, how long should you go on with all the diagnostic testing? 15 years, 20 years. It depends on the risk profile at the beginning. It depends on your genetic alterations observed in your initial biopsy or surgery specimen. So keep that in mind. You have to ask for it at the pathologist, or at least the samples should be stored somewhere and to do the testing afterwards. What also can be observed in this study is that 50% of the recurrences are observed within 5 years, and 50% of the recurrences are located in lymph nodes. And that is why ultrasonography is highly important in the first years of follow-up. Of course, also a local recurrence in the thyroid bed can be observed in about 25% of the patients. Distant metastasis can be observed, but again, it depends on the initial tumor, whether we're dealing either with follicular or papillary cancer, whether we're dealing with local recurrences or distant metastasis. So papillary thyroid cancer, Usually local regional recurrences observed within 5 years, and the distant metastasis, you see a slight ongoing incidence rate, and that means that in follicular cancer the follow-up might be slightly longer than in papillary thyroid cancer. But data in literature are scarce on this respect, on this item. I told you yesterday that one of the most important things is that if a patient presents with thyroid cancer, you have to do your best when he presents. In fact, at that moment you will establish his prognosis. So optimal surgery, optimal ablation, that is what prognosis influences. That's the only thing we can do from a clinical perspective. We are lucky because usually at the initial stage there is cancer induction, there is still sodium iodine symporter expression on the cell surface. However, the longer we wait, the higher the chance of dedifferentiation. I will come back later on that, because sometimes we say, okay, we wait and see what's going on with the patient. Keep that in mind, that this is the moment to hit the cancer cells with radioiodine. So if a recurrence is observed, go for it and give the most optimal radioiodine therapy, because during follow-up you may lose the battle if dedifferentiation occurs. And that means that in the first 1, 2, 3 or 4 years, give as much radioiodine as possible as long as there is uptake. Don't wait too long, and don't wait for the dedifferentiation process. The problem is that we really don't know at what time point this may occur. But at least what we know is that when patients present with recurrences, and we look at the whole group, the whole study population, at the end 50% of the patients with recurrences may have dedifferentiation. I'm not talking about all patients, I'm talking about the patients who show recurrences during follow-up. And that means, again, you have to start here. You have to do your best here, and don't wait too long for that. But there are circumstances that may be the basis for personalized medicine and wait-and-see policies. Now, based on these data I just presented, again, the standard follow-up is only stimulated thyroglobulin levels and ultrasonography. And you see here, you have to do this testing 6 to 12 months after your initial ablation. And don't forget to do that, because you might miss the local regional recurrences. If there is doubt about the presence of distant metastases, go on for other testing. But you see here how the flowchart has been developed: undetectable thyroglobulin levels, normal ultrasonography. You can send the patient safely home, and if there is a detectable thyroglobulin level or ultrasonography shows abnormalities, you have to go on with your treatment. Well, again, this is based on the sensitivity and the specificity of all tests, why we should apply stimulated thyroglobulin levels and ultrasonography. It is good to realize the stimulated thyroglobulin levels have a higher sensitivity than the unstimulated thyroglobulin levels. So don't forget recombinant TSH or hormone withdrawal. You get the best idea of what's going on in the patient. Well, this is quite simple. This is the standard care, this is standard follow-up. It's written in all guidelines. You can follow the guidelines. But then, what are we going to do when there is a discrepancy between thyroglobulin levels and your imaging techniques? And what are we going to do in the other way? So elevated thyroglobulin levels, normal scans, and the other way around. And then we have the option of using such techniques. Of course, ultrasound remains important for the detection of local regional recurrences. It is rather sensitive, however small lesions may be missed, definitely. So if ultrasonography is negative, but you have positive thyroglobulin levels and you have no idea where it is, you have to go on. CT scanning, of course, for the detection of local and metastatic disease, it's sensitive, but it's not used as a standard technique for whole body imaging, usually to assess the lungs. MRI, the detection of local and metastatic disease, but again, as told you yesterday, FDG PET scanning, it is for the detection of metastatic disease and providing prognostic information, highly important. So if there is doubt about the localization, the recurrence, or whatever, and there is a discrepancy between thyroglobulin levels and your imaging techniques, then you should think about FDG PET scanning. Well, the diagnostic accuracy of FDG PET scanning in the follow-up of papillary and follicular cancer is high, and that has all to do with changes in glucose metabolism over time. The lower the radioiodine uptake, the more we're dealing with dedifferentiation, the higher the glucose and subsequently the FDG uptake in malignant cells. And this was one of the first studies in patients with elevated thyroglobulin levels and negative iodine-131 scans. And again, don't forget, if you're going to do an FDG PET scan, give the patient recombinant TSH. Why? This is why. The number of lesions you may observe is definitely higher when you use recombinant TSH, but also the SUV values may alter when you use recombinant TSH to stimulate the uptake of thyroglobulin in the malignant cells. Don't forget it, because it has prognostic value. It has definitely prognostic value. In the follow-up, I told you yesterday the role of iodine-124 PET scanning. I'm not so sure about it. We know that the sensitivity is rather low. It is better when you're using recombinant TSH. Again, the uptake will improve when you use recombinant TSH, but the sensitivity is dramatically low compared to FDG and other scan techniques. And if you still think that there is uptake of radioiodine, give a blind treatment and see what you may find on your post-treatment scan. The sensitivity of that technique is much higher than by using iodine-124 PET scanning nowadays. Maybe it may improve, but the data are not very supporting this technique. Now that's all about how to visualize and how to detect recurrences. But what are we going to do about it? These are the treatment options during follow-up we have. Surgery, radioiodine, radiotherapy, wait and see, chemotherapy, targeted therapy, and redifferentiation therapy. That are all the options we have when we're dealing with recurrent disease. Quite simple. But the question is, what are we going to do? What are we going to implement? What are we going to give to the patient? Well, there are some tumor-related variables. The site of recurrence, the size of recurrence, number of lesions. I've shown you in the previous slide that the higher the number of lesions, the poorer outcome will be. You have to keep that in mind. If you're dealing with multiple lesions without iodine-131 uptake, well, what should you do? And discuss it with your patient before you start giving highly toxic agents. iodine-131 uptake, growth and clinical course. What do you know from history from the patient? How rapid is the turnover? What is the increase in size during follow-up? Does it take 1 or 2 years, getting from 1 to 2 centimeters in diameter, or is it 3 months? That is highly important to make your decisions. And of course, there are patient-related variables. Age. It's completely different when you're dealing with a young female patient with metastatic disease coming back, multiple lesions in the lung, than when you're dealing with an old woman 80 years of age or an old man 80 years of age. Keep that in mind. Concurrent disease. Are there other factors influencing what you're going to do and which options you can apply? But there's only one thing you have to keep in mind. Despite the recurrences, and especially during the first years after initial diagnosis, thyroid cancer is a rather benign disease. But dedifferentiation may occur. But take your time to make your decisions. Don't rush, don't hurry, but do it good. That is highly important. Okay, when we talk about recurrences, I told you papillary thyroid cancer, a high chance for local regional recurrences. And what we know from papers in literature is that surgery in advanced thyroid carcinoma is the best modality used for recurrent neck metastases, since most recurrences are seen in the thyroid bed or regional lymph nodes. And then it says, this is usually followed by radioactive iodine, especially if the recurrence is avid, radioiodine avid, along with thyroid hormone suppression. That's questionable, because what do we know from the data and literature on the value of radioiodine in recurrent disease after surgery? Who knows? What we know from the data and literature, in fact, is quite simple, and it has been implemented in our Dutch guidelines. When lymph node metastases are more than 1 centimeter, surgical resection is recommended. You're dealing with macroscopic disease, and the best way to treat that is surgery. Don't forget it. It's the best step you can take from the beginning on. However, when there is clinically occult local regional recurrence in the neck, less than 1 centimeter in the size, demonstrating uptake of iodine-131, iodine-131 therapy may be the best choice. What I know and what I've learned from surgeons is that they want to perform surgery only when they can feel the recurrence. They will never do a neck dissection in case of microscopic disease, when there is doubt about where it is, what you can find. How far should you go? As long as there is radioiodine uptake. And in all other cases, microscopic disease, when the surgeon is not willing to do surgery, no uptake of radioiodine, then radiotherapy might be an option in case of extranodal disease and either radical resections without iodine-131 uptake. Now, what do we know from the data and literature on the value of surgery in case of local regional recurrences? You see here some papers presented. What can be seen is that in 70% or 27%, a biochemical response can be observed. 51%, 71%, 72%, a complete biochemical response. And what does it mean for nuclear medicine thereafter? If a majority of the patients can be cured with normalization of thyroglobulin levels, what are we going to treat with radioiodine? Disease that's not present anymore? Possible microscopic disease, but we have no idea where it is. So what are we doing when the thyroglobulin levels have normalized? Big issue, big problem. There are some studies in literature that have dealt with this problem. You see here a study in 2011. It was a retrospective study. 23 patients underwent lymph node dissection, in fact, a complete resection of tumor combined with radioiodine therapy thereafter, and 22 patients without iodine-131. And overall, iodine-131 did not cause significant differences in the overall outcome. So if there is already a biochemical good response after surgery, it's questionable what we are doing. There are some studies that have said, okay, there is a complementary role. Ronga, Ross, Simpson, you can find it on PubMed, you can go to these studies. But you have to realize that in many cases, these patients did not have a complete biochemical response after surgery, and that is why they stated there is a complementary role. And here again, you see recurrent thyroid cancer, the role of surgery versus radioiodine, patients who underwent surgery alone or surgery with radioiodine, the differences in survival rates, but also in recurrence rates, was not significant. And that means you have to be very careful in applying radioiodine for disease that you have not detected. So the take-home message is quite clear. In case of a local regional recurrence, when there is macroscopic disease, you have to perform a resection, or the surgeon has to do that. And then thereafter, if thyroglobulin level was elevated and it normalizes after surgery, you can wait and see and do a thorough follow-up. 6 months after surgery, you do thyroglobulin testing, ultrasonography, and in fact it is a restart of your whole follow-up procedure. If thyroglobulin remains elevated after surgery, you have to restage the patient. Another option is, because you're dealing with probably microscopic disease, you can treat it with radioiodine. And that is what you have to discuss with the patient. That is what you have to discuss with your team. Are we going to treat the patient straightforward with radioiodine, or do we want to know where the other lesions are located in the body? You will probably find them on the post-treatment scans, but sometimes you have to do a CT scan or other tests. And what if we are dealing with dedifferentiated recurrences in the head and neck region? Well, again, surgery is the best option. Usually, radioiodine doesn't work anymore, and then it can be followed by radiotherapy or other treatment options, but it depends on what has been found and what has been resected. Now, what about the distant metastasis? In fact, that's quite simple. If there is iodine-131 uptake, yes, treat it. You have some time, but hit as much as you can, as hard as you can. So use a high dose. Why do we need a high dose? I told you this morning, I showed you later on also, the uptake in malignant cells is not as good as in normal thyroid tissue. So don't think that with 1100 microbecquerels or something in that range, you will cure the patient. No, you definitely need a high dose, 200 millicuries. Be careful if there are pulmonary lesions. I showed you in the previous talk, if there are multiple lesions, you may end up with fibrosis, and that is an indication to lower the dose. So don't give then 200 millicuries, but lower the dose. That is a reason to adapt or to adjust the activity. There is some discussion in literature about the resection of macroscopic tumor lesions. If a patient is coming back with a large recurrence in the head and neck region and pulmonary lesions, it has been stated that if you're able to do a resection of a gross part of the tumor, it might be helpful to increase the uptake in other lesions. There's more radioiodine available for other metastatic sites. But it has never been proven in literature that it improves the overall outcome. Usually, it's because of other prognostic factors. If a tumor is growing into the vessels in the head and neck region, yeah, that is of prognostic value. If you get a blowout, a vascular blowout due to a recurrence, the patient will die immediately. Now, that is what you want to prevent. But whether it increases the uptake of radioiodine in other metastatic sites, it might be, but data is scarce. Now, what if there is no uptake of radioiodine? Then we are really running into problems. There is no indication for radioiodine anymore. But what then? Radiotherapy, maybe radionuclide therapy when there are bone metastases. And if a patient has metastases solely in the bone, it might be an option. If they are painful, you have to do radiotherapy. If they're not painful, you might treatment when there is good uptake on the bone scan with samarium or strontium or whatever. Don't forget that treatment option. And then thereafter, of course, chemotherapy and targeted treatment. The only thing I want to comment on that is if you're going to apply such techniques, please do it in study. Don't do it on yourself, because it's only a single case you're usually treating in thyroid cancer. And hopefully, especially with new drugs and new agents, be part of a study, a multi-center study, when you are going to apply such new agents. But if there is no uptake, FGG PET is recommended to assess dedifferentiation and to assess or to get a complete view of what's going on. Where are the sites of metastasis? Where are the lesions? Sometimes a wait-and-see policy can be recommended, but the problem is, I told you, or the problem might be, dedifferentiation. So you may wait and wait and wait, and especially in such cases, slightly elevated thyroglobulin levels. You talk about levels ranging from 2 to 5 or 2 to 10, depends on what you use for tests in clinical practice or what your cutoff values are. But what are you going to do with values like that? Stable over time, and additional treatment has not been given. Who is going to treat this patient blindly? Again, the 3rd dose, the 4th dose of radioiodine, the 5th dose. Well, sometimes it's better to wait and see how it goes. Maybe there is no indication for radioiodine therapy, but again, if there is doubt about the tumor load present, and you may especially think after 5 or 6 years that dedifferentiation may be a problem in that case, do a PET scan. After the lymph node dissection, normalization of thyroglobulin, I told you, I showed you. In fact, when a surgeon is able to normalize the thyroglobulin level, what is the indication for radioiodine therapy? Maybe it's better to wait, and when it rises again or elevates again, you can give your radioiodine treatment. So that might be an indication to wait and see how it develops. And another important issue, some patients have clearly elevated thyroglobulin levels, 1,000, 500, 100, 20,000, and it remains stable over time. It's rare, but sometimes meet these patients and they do not respond to radioiodine therapy. Well, what are you going to do? Alternative drugs, radiotherapy, etc., etc. Make up your mind and see what's going on. And if a patient is 80 years of age, what are you going to do? Are we dealing with dedifferentiation? What are the treatment options? And when we talk about other treatment options, what are the side effects of the new treatment options you're going to give to these patients? Now again, when a patient is young, yeah, maybe it's time to go for another drug. But in the elderly patients, there is no need to take everything or to use everything or to apply everything in clinical practice. But it's all matter of discussion. That is really personalized medicine. Now, in fact, based on this is the flow chart we use during follow-up with subsequent steps. Thyroglobulin measurements and ultrasonography, that is the base of standard follow-up. If both diagnostic tests are negative and the risk factor is low, the initial risk stratification is low, wait and see, do a good follow-up. If the patient has a high risk profile, a thorough follow-up. You have to go for a thorough follow-up. And if there is doubt about the presence of tumor and ultrasonography and thyroglobulin levels are negative, think about PET scanning at this stage. If thyroglobulin levels are positive and ultrasonography is positive and you're dealing with a local regional recurrence, go for surgery. Thyroglobulin response, yes, normalization, thorough follow-up. No response, go for radioiodine therapy. It's quite simple. Now what about this? And that is in fact the whole dedifferentiation area. Either negative thyroglobulin levels, but abnormalities on ultrasonography, or positive thyroglobulin levels and negative ultrasonography, both diagnostic problems, and that means you have to go on with additional testing, CT, PET-CT, and again, patient's history is highly important in your decision. If there is a local recurrence, macroscopic disease, surgery, then make up your decision. If it's microscopic disease as a local recurrence, give INE-131 therapy, and if we're dealing with distant metastasis, again, INE-131 therapy, and it depends on the size of your recurrence, your local regional recurrence, whether you add surgery to it or not, but it depends also on the experience of the surgeon. Okay, radioiodine is not an option anymore. I told you surgery might be one. If there's no uptake, but you know there is only one lesion in the head and neck region, ask the surgeon, call him, and go ahead. If it all fails, external beam radiation for local regional recurrences is a very good option. Percutaneous ethanol injection therapy, in fact that's only when there is local recurrent disease, patients that are not responding to the local regional treatments, but it is rarely applied. And finally, the last option, when it all fails, no radioiodine, no surgery, no radiotherapy, there are distant metastases, we can go for the systemic chemotherapy, including the tyrosine kinase inhibitors. And that is usually in unresectable radioiodine refractory metastatic disease. But you have to realize, when applying this, significant adverse events may be observed. To my knowledge, you will hear something about TKIs tomorrow. It's one of the topics, so I will not go very deep into this topic now. The only thing I want to comment on that the TKIs are in fact one of the cornerstones in activating signal binding sites or deactivating binding sites, signal binding sites. So what you want to do in fact is stopping the whole signal cascade by blocking this pathway with the TKAs, but you will hear more tomorrow about it. This is the general practice. You see here all types of inhibitors presented. You will find it also in the handouts. And there we are again. I told you it is highly important to have knowledge on the genetic alterations. Don't forget to ask the pathologist what he has found. Why is it so important? BRAF inhibitors, and there we are. I told you it's probably one of the cornerstones in thyroid cancer, in dedifferentiation, in atypical thyroid cancer. And there are other MEK inhibitors, etc., which may be useful in differentiated thyroid cancer. Well, these are in fact nowadays the inhibitors used in thyroid cancer: sunitinib, sorafenib, pazopanib, all acting on another part of the metabolic or on the signaling pathway. But again, you have to ask for a genetic profile, whether it will work or not. What are the results of these targeted therapies? Sorafenib, sunitinib. This is in fact how it works, which signaling pathway it will block. And you see here the response rates. Partial response in 30%, partial response in 40%, 28%, 49%. It has consequences for the progression-free survival, but overall prognosis remains very poor when you have to apply such agents. And another important issue, of course, are the adverse events observed when you apply inhibitors in differentiated thyroid cancer. Hypertension is not the problem. I mean, you can manage that. Weight loss, anorexia, diarrhea, you see, they can all be observed. So be very careful, be very careful. Hand, foot, skin reactions, 30% of the patients. So it's not nothing we're talking about. So if you're going to apply inhibitors, there should be a base for it. There is no way of treating the patient in another way anymore. But again, my opinion is that when you want to apply the inhibitors or other new drugs, please do it in a multi-center study or a single-center study, but not just as a treatment agent. My last slide, differentiated thyroid cancer. We have a standardized treatment and follow-up, which is available, applicable, adaptable, and adoptable in clinical practice. Overall, and don't forget it again, the prognosis of thyroid cancer is really pretty good. But if you're going to treat the patient with radioiodine or whatever, do it as good as you can to prevent dedifferentiation, to prevent high recurrence rates. And if dedifferentiation occurs, of course there are still drugs available, but again, it is personalized medicine, and in fact, we switch from personalized nuclear medicine in the course of the disease to personalized medicine. That was what I wanted to say. Thank you.